It started off that I was bound and determined to do graduate surgery after getting my Australian fellowship in general surgery, and that meant subspecialising, and the area that I eventually chose was that of colon rectal surgery, which was rather serendipitous because about that time Rupert Turnbull had come from the United States, from Cleveland to Australia, where he was on this several major cities tour and giving lectures as he went, predominantly on the no-touch technique, for which he was most famous. He then came to the hospital where I was a chief resident, at St Vincent's Hospital in Sydney, and then there was a series of major medical meeting going on downtown to which I was privy to go, and there I was able to be excited by the concepts that he espoused, things like the no-touch technique in particular, surgery of ostomies, and it was clear that there was a whole vista of surgery that was beyond my ken, something which I hadn't realised how far advanced this was compared to what I'd been trained in. So with that, and with the fact that I'd also had a chance to get a advanced fellowship in hepatobiliary surgery at the Leahy Clinic, I was able to couple those two programs together and follow the hepatobiliary with Ken Warren at the Leahy Clinic to Rupert Turnbull one at the Cleveland Clinic. That's how it all started.
Vic, as a leader of one of the major clinics in colorectal surgery, tell us how you feel the role of the clinics has progressed our specialty.
Well, it's an interesting question, but I think a lot of the organisational aspects of colorectal surgery have come from some of the major centres, and we all know what they are, but there might be, say, 10 of these such centres, including, of course, Mayo Clinic, Leahy Clinic, Cleveland Clinic, and several others. And what they've been able to do is to add to the concept of subspecialisation within a specialty of colorectal surgery, which in turn has led to other subsections of specialisation coming up, like particularly intrastomal therapy, oncologic surgery, ostomy surgery and its evolution, as well as many others. Diverticulitis is one that comes to mind, Crohn's disease is another, and here is where the subspecialties have particularly thrived because it's mostly in these arenas in different hospitals where the concepts of super subspecialisation has emerged and has served as a bit of a model for those who aspire to go into our specialty, where they can, to a certain extent, apply to the programs which most relate to what they particularly want to see. At that particular young stage in their careers, they're not quite sure, as I was not quite sure, of the gamut of the specialty at that time. So we would then apply to those programs which were noted for their breadth and depth, previous historical accomplishments, and use that as the way in which we would apply for, and the particular order in which we'd apply for subspecialty training.
Vic, you were the third editor of the journal, I think,
Yes.
and for 10 years. How, over that period of time, did the journal adapt or evolve?
That's an interesting question because, to start with, it was a one-man show, and there was no bones about it, but that the first person who took this up evinced what the principles of the journal would be about, and it's to publish those articles of interest to the readership and to maintain high quality. Well, subsequently, that concept has continued, and more as others before me, and subsequently myself and others that followed me, have tried to identify those areas which might be called areas of concern or questionable areas, ones where we need hard evidence randomized controlled trials and things of this nature to bring up the overall quality of the journal, which we've seen over these years, and in subsequent senior editorships we've seen that go forward. So that, and getting an advisory group or the co-editors of the journal together, selected on the basis of merit, we've been able to, I think, advance the cause of the journal to a significant extent, and I think there's little question that on the international stage anyway, the journal Disease of the Colon and Rectum is the premier #1 journal for disease of the large intestine, and getting to be diseases of the small intestine as well.
Vic, you've had a relatively long and distinguished career. Looking back over those times, what were some of the major challenges you had to deal with?
That's an interesting question, the major challenges. Well, I think starting off, it was a major challenge to be able to follow through on what might be called the ethic and the vision of my predecessors, Bob Beert, and of course the origins of all this with Dr. Bowie. But in addition to that, it's to try to bring together a rationale for the journal. And by that I mean that we have good quality editors who are able to be critical without being offensive, who are experienced and skilled in their own subspecialty areas of interest, and that most of the domains which we cover in specialized colorectal surgery were covered, ranging from the relatively so-called simple ones, anorectal surgery, to resectional surgery, surgery of ostomies, inflammatory bowel disease in particular, and of course cancer. And by bringing all of those things into alignment and trying to select out associate editors who had got some skills in these areas, then we were able to establish the who's who to send out abstracts, or send out rather papers, to people who would be able to be constructively critical of the papers, trying to make it acceptable and better than what might otherwise not be the case. And these, I think, we've been fairly successful in doing. And with succeeding appointments of co-editors, as we've done in the last 15, 20 years, and with the established expertise that they've shown, that I think we've been able to gradually increase the impact factor of the journal, one of the major measures of how successful a particular journal is, which is no mean feat when you consider that there are so many specialty journals out there that simply getting a who's who list of subspecialty interests to be able to target a particular paper to a particular person or group, to critically analyze it, point out the pros and cons of the paper, and above all, point out where it could be improved, because we were, after all, not in the business of being hypercritical, but rather trying to constructively add to the value of the submitted manuscript, so that we were there basically to try to help the person doing the submission to make the journal better. And I think over the years, the fact that the impact factor has increased and the, I think, quality of the editing has increased, after me certainly, that this has been achieved to a large extent.
Vic, looking over your long career, what are 2 or 3 things you're most proud of?
Wow. Keeping strictly to medical-surgical aspects as opposed to family, and being in trouble with my wife if I don't put her and the family up there #1, I would say that the big ticket items for me have been the opportunity to work with excellent people, and by that I mean Rupert Turnbull, who was a mentor, if not a mensch, but certainly a mentor and someone to aspire to that degree of excellence. Secondly, I would say it's the ability to work with, in a collegial fashion, after being selected chairman of our Department of Colorectal Surgery at a fairly young age. I was 34 when that occurred. And then to witness the gradual growth of the importance of the journal on the national and international scene, how that, I think, was one of the major things which I feel very proud about.
Is there anything else you'd like to, for people watching this video in years in the future, things you'd like to leave them with?
I hadn't thought exactly about that question, but what I would say is this, that everyone who's practicing our specialty can and perhaps should develop a niche area in which they can be not just specialists, but even super specialists. And that can be in as simple formulas as how to be able to advise younger surgeons on a career in our field, to point out what the value of that is. And it's not just the scientific part of it, but the collegiality that comes with being a mensch or a mentor of sorts to help guide them in their career choices. Over and above that, I think it's a great opportunity to see how others in the more pronounced programs have been able to do it. And that's been based on a couple of things, but basically it's developing good databases right from the beginning. Good databases are those where you can start off by asking a question which you want to get answered, or more generally, if it's a good program, you'll get these databases going in all the major areas of our concern, from anorectal disease to colon resections, to IBD, to diverticular disease, and to cancer, of course, as well as ostomy surgery. And for each of these, there is a way of gathering data that is significant, and developing the database so that it is able to answer many of these questions, I think, is of great moment. And if you can develop the database and get the wherewithal to have that filled out, monitored, then you have the capacities for having high quality journal articles come out, as opposed to the old style one of see one, do one, teach one. We can now put some data behind all of this, not least of which is the how-to technique and what to do and what not to do in certain circumstances. So those, I'd say, are the major things I've been able to get out of doing the editorship and trying to be somewhat creative, but also learning on the way. I mean, my best education has come about from papers that are submitted to the journal, and then trying to develop the techniques of being able to critically analyze them and rate them as journal worthy or not. And so I have to say that I learnt a lot from just being in that position.